Welcome back, and welcome to people in WebEx land. Wasn't that a good lunch? Thank you to the staff at TCU Place. Now I'd like to welcome Jacqueline Arthur, who is Manager of Strategic Issues, Centre for Communicable Diseases and Infection Control with the Public Health Agency of Canada. And Jackie is a registered nurse with a long and illustrious career in public health. I will also point out that in your folders is a paper copy of Jackie's presentation if you'd like to follow along and take your notes there. So thank you and welcome, Jackie.
Thank you. Good afternoon. I love the fact that I'm the first presentation after lunch. I usually am either like first thing in the morning when people aren't awake and talking about federal stuff bores people, or it's at the end of the day when half of you've gone. So I'm thrilled to be here, and thanks to Bob and Valerie and the planning team for inviting FACT to be a partner in this session today. We did a similar type of approach with the Atlantic provinces back in June, and we thoroughly we're impressed with the quality of the programs that go on at the local and regional level, but also how people are willing to share and learn from one another going forward. So we're hoping for the same will happen today. So just to give you a bit of background, the federal government has a very specific role that it plays vis-a-vis health. And as you can see, from the slide, it really centers on providing the leadership and coordination to bring people together to convene and talk about the pressing issues of the day. And in this case, antimicrobial resistance is definitely a pressing issue. And we have, as a federal government, signed on to the WHO Global AMR Action Plan and committed to developing a national plan by next year. So you will see that I shamelessly promoted our Pan-Canadian framework, that I put resource copies on your tables, but I also gave you the link so that you can download it and look at it at your leisure. So this slide just gives you a sense of how complex the issue of AMR. Most of you are in this field. You know how complex it is, the number of players. Certainly we have human sector players, animal, agriculture, agri-food, food, environment, and that's why we talk about all the time a One Health approach is needed. The roles and responsibilities are varied among the different sectors, but they all need to come to the table. They all need to identify where their responsibilities lie and what role they can play going forward. So I won't spend a lot of time on statistics because Lenora did talk about this morning, but certainly our latest report that we released on Friday from the Canadian Antimicrobial Resistance Surveillance System, we can see that we have 22.6 million prescriptions dispensed in Canada. And of that, we know that the vast majority are in the community setting. The good news is that we're starting to see a downward trend in the antimicrobial prescribing rate of physicians. And we're now also looking at dentists and trying to get a sense of how dentists are prescribing. They prescribe a much lower percentage than physicians, but certainly between 2010 and 2012, we're seeing a generally stable rate after that time. There was an increase and now it is stable. In the hospital setting, purchasing of antimicrobials is relatively stable, but of concern, hospitals in 2016 purchased more of some of the antimicrobials we consider last resort, such as dapamycin, than in previous years. And we often know why that is, because they're dealing with much more complex care patients. On the animal side, AMU has decreased for the first time in 2016. There has been a notable decrease in the use of fluoroquinolones, with the overall quantity distributed for use in animals decreasing by about 56% between 2015 to 2016. So there are some good news stories to share. In terms of AMR, We are seeing overall stable rates, but there are pockets of real concern that we need to be paying closer attention to. Specifically, there's upward trends in MRSA infections in pediatric hospitals, and also VRE bloodstream infections in adult hospital care. And of course, drug-resistant gonorrhea is alarmingly more and more of a concern. Resistance cases rose from 2014 to 2015. And so we do need to be paying very close attention because more than 50% were resistant to at least one antibiotic. So others have alluded to this morning about the Government of Canada's response to AMR. And so 2014, the Government of Canada pulled all of the implicated government departments and agencies and released the federal framework for action. And so that included the Public Health Agency, Health Canada, Canada Food Inspection Agency, Canadian Institutes of Health Research, Agriculture, and Agri-Food Canada. And then in 2015, we developed an action plan, and we committed to delivering specific initiatives to respond to AMR. So I'm here today to talk about the Public Health Agency areas of action, and some of those I've already alluded to in terms of leadership and convening. But we have a key role to play in surveillance, and data, and others have mentioned this already, how important data is in filling in the picture of what's happening on antimicrobial resistance and antimicrobial use in Canada. We also are very involved in public and health professional awareness, as well as prudent and appropriate use of antimicrobials and stewardship overall. A lot of what we do is working in partnership with others to ensure that we've got at least between ourselves and our key players, some initiatives that are looking at new and innovative ways to improve antimicrobial prescribing. So this turns me to the Pan-Canadian framework. So in September 2017, this framework was released by the Government of Canada. It uses a One Health approach, and it looks at it from a federal, provincial, and territorial lens. There were several working groups, what they call task groups, that lots of different experts and stakeholders were involved in. And I think a couple of folks that were on some of those task groups are in the room today. This framework really focuses on 4 key pillars: surveillance, infection prevention and control, stewardship, and research and innovation. It's the first document in Canada on AMR that really does speak to what all levels of government have agreed to. And that's something very significant. In fact, this document was actually ready to go in terms of the text last March, but it took 6 months to work through seeking all approvals to ensure that everybody was comfortable. And so this is a good document to use as a basis for our forward thinking and planning. So I want to focus specifically in the Pan-Canadian framework on the stewardship opportunities for action, because I think that will be very helpful in our discussions tomorrow. And so there are 4 key areas that we need to consider. The first one being about creating the networks and ensuring ongoing leadership and coordinated actions. That is going to be crucial for any work that we do collectively going forward. The second one is data, and I don't think we can stress it enough how important data is. And so we need to look for ways to continuously improve how we're collecting data, what data are we missing to be able to give us a full picture of antimicrobial use as well as antimicrobial resistance. And it has to be across the human and animal sectors. The third area is governance, and that just, it includes regulations, it includes accreditation, but it also requires consistent standards. We can all point to different guidance or standards that we use for our antimicrobial prescribing, And that has to change. We all have to come together to decide, well, if at a provincial level or at a regional health authority level we're going to be consistent and use specific guidelines, then let's make sure that we're all using the same ones and that we all have access to the same antibiogram data. That will certainly help us in improving antimicrobial stewardship. And then the fourth area is building knowledge about stewardship. And that includes continuing education. It was mentioned this morning about our upcoming new prescribers, new clinicians during their curriculum, ensuring that there's the right kind of discussions that are happening in the classroom around resistance and stewardship of antibiotics, but also continuing education. And that's where the federal government can also play a role. The other area is public awareness. So it's not just on the prescriber side, but it's on the patient and the public side. Do they really understand when they're taking antibiotics, that there is a downside? Do they really understand that when they go to the doctor's office and they say, I really want X, or I really am sick, I need something, or I need a doctor's note, but it helps if I'm given a treatment, and then they feel that they can take time off work. All of those things get messed up into the discussion with the prescriber. And so we really need to help the public understand this issue at a very grassroots level. So you see slogans all the time of superbugs and the tsunamis, but it's not resonating with the public. The work that Dr. Sir Jim O'Neill did on behalf of WHO, looking at the $50 billion cost of AMR in 2050, that still doesn't resonate. It may resonate with me and where I sit in the federal government, but it doesn't resonate with the public. So we have a lot to do in that area. I always love showing this slide because it is a little overwhelming. And it just gives you an idea of the complexity of the governance in this country when it comes to antimicrobial resistance. So on the right-hand side of your screen is the animal health sector, and on the left-hand side is the health sector. And in between, they come together. And this is the governance structure to, first of all, identify what needed to be in the pan-Canadian framework, but this is the governance structure that is going to be used to develop the actions that everybody agrees upon. And when we say actions, the expectation is that people are going to come to the table with very concrete activities, with timelines, and to be accountable for the delivery of those actions. And I mentioned earlier there were a couple of people that were on the task groups. If you're in the room, can you put up your hand if you were on one of the task groups? There's one at the back. There's, yes. Any others? So I'm sure they'd be happy to talk to you about some of the complexities of the discussions that went on in those task groups, because it's a challenge when you're looking at trying to agree on an action plan, or at least for the framework, what are those key areas going to be? So the next steps. Really, as I mentioned, the actions that the federal, provincial, and territorial governments will be looking for will focus on those four pillars. They have to be concrete, and the outcomes and timelines have to be clear. And also, we have to continue with a One Health lens. I attended a meeting almost 2 months ago, that there was a panel discussion that did a pro and con approach of, should we do a One Health approach to AMR or should we not? And it was a fascinating discussion because it really wasn't a pro and con. It was just, how can we do it? How can we do it quickly? And how can we do parallel? And so I think just to consider that when we know of the complexities of this issue and we're looking at it from a One Health approach, it doesn't mean we need to do everything all the time together. It just means we need to be aware of what each other is doing. We need to see where there are those synergies, and then we need to arrive at the ultimate achievements together. So in my presentation, I've included some resources for you. The latest, as I mentioned earlier, the Canadian Antimicrobial Resistance Surveillance System, a report that was released on Friday, the Pan-Canadian Framework, which I mentioned earlier, as well as the framework that the federal government put out a couple of years ago. And also, since it is Antibiotic Awareness Week, I hope you all made the pledge to antibiotic wise.ca. If you haven't, please go to that website and sign on. It's being led of the BC government. And so please sign on. As well, there's been activities through the National Collaborating Centre for Infectious Disease for a thunderclap. And so if you haven't seen it already, I hope you will see some of the messaging, hashtag keep antibiotics working. And that is the end of my presentation. Thank you very much.
Thank you very much, Jackie, and thank you for joining us here from Ottawa. We really appreciate your help and support. And the Public Health Agency is also a co-sponsor of this event and provided us with some cash to be able to put it on. So thank you, Public Health Agency. Next, I would like to call upon Yvonne Shevchuk, who is Associate Dean, College of Pharmacy and Nutrition at the U of S and Director of MedSask.
Is it on the big screen? It is. Oh, okay. All right. Sorry, I'm technically challenged, so.
So just forwards, backwards.
Yeah. Okay. Thank you very much for inviting me to address you today. I was asked to talk about current issues, and so for me, current issues is in human health. But I do want to recognize, as everyone has said today, the One Health approach, and just skimming through the list of participants, noted there's lots of veterinary colleagues here today, and so that's great. I think that's a wonderful opportunity for us to have conversations together. I will also say that there's nothing I'm going to say in the next 10 or 15 minutes that you haven't already heard this morning. So that could potentially lead to maybe not the most exciting presentation. But I've also learned in education that repetition doesn't always hurt. And so perhaps bringing home some of these points might in fact be useful for us all today. So, current issues from my perspective. There are many challenges facing Canadian healthcare system today, and all of them have an impact on patient safety, as does antimicrobial resistance. So I think we all have heard lots about the opioid crisis, mental health issues that face many of our population, including, heartbreaking suicide rates amongst Aboriginal youth. I mean, how can we make priorities when we're faced with such challenging issues? We are a self-selected group here, and we understand the gravity of antimicrobial resistance and some of the challenges that we face. But in my interaction with different groups and different people, AR doesn't make daily headlines like some of the other problems, and so we really must be pretty dedicated and persistent in putting this issue forward to the public, to other prescribers, other healthcare professionals who maybe see the other issues more as a priority or more at hand, government officials and policymakers. We have to ensure that it remains a priority. I actually had the honor of presenting last week to the Standing Committee on Health, and their questions were very basic. Their understanding of the issue, I think they understand that it should be thought of as a priority, but they have difficulty seeing where in the big scheme of things it might actually fit, to be honest, was one of my impressions. Measurement has been talked about today already by many people, and I don't necessarily sort of want to harp on this, but what you measure gets monitored and done is a phrase that I hear a lot, especially in quality improvement circles. And as been mentioned, we have at best very spotty and fragmented systems for monitoring antimicrobial use, but that doesn't mean we can't change those systems. I think back to, and I said to somebody at the table I'm sitting at that I've been around so long that I can actually, remember the rehashing of things, and I also can probably, maybe offend people, and people will just say, well, that's just Yvonne again. But anyways, I remember back, there's an information system in Saskatchewan called PIP, the Pharmacy Information System. And back when I was asked about my opinions of PIP and there were consultations, one of the things that some of us said we need the diagnosis in PIP. We have to know why drugs are being used, not just antimicrobials, all drugs. How can pharmacists do their job if they don't know what the drugs are for? And we lost that battle and we've regretted it ever since. But why can't we change that now? As an example, we can certainly add that to PIP. So I will get off my soapbox about that. But I saw Jackie put up a slide that indicated that Saskatchewan has the second highest antimicrobial use in the country. I'm constantly asked, why is that? Because we're usually up there in the top 3, and I don't know the answer to that. And I think that we need better data in order to be able to answer those kinds of questions. So natural standards for measuring use, so appropriate comparisons can be made and problem areas can be identified. And again, people have said this or said this already today, but I felt compelled to mention it. Allocation of resources is also a challenge for all of us. Again, there are many priorities in the health system, and all of them need resources, or at least rearrangement of resources, in order to be dealt with or challenged. So it's difficult sometimes for those of us at the front lines to convince those who hold the purse strings to actually invest in antimicrobial stewardship. And it may be particularly difficult for the smaller institutions who are trying to do this off the side of their desks. So one of the, things that I wanted to make you aware of is that there is a committee of AMI that did develop actually a template to create a business plan. So I think this is a huge step forward. The template is free of charge. I've put the locations there, and what you do is you simply enter your own hospital's information, and it will give you the outline of a business plan that you could present to your hospital administrator in order to look at what a plan might in fact cost an institution. So I think that is an important first step. We're also just in the process of publishing a second paper that outlines the actual number of FTEs of different health professionals in sort of the ideal ASP from a Canadian perspective, and that's not done before. And so we hope that being able to have that data will be useful for people as well. So you will have seen that a lot of our information and a lot of the data we have is in institutions. So I think another big issue for us is antimicrobial use in the community. As I said, more than 80% of prescriptions are in the community. So this requires really a very different approach. A lot of the strategies that are outlined in institutions simply don't work. Can you imagine being the pharmacist who calls up the patient and says, well, that $70 prescription I gave you yesterday really wasn't the right antibiotic. We now have some data that tells us we can narrow the spectrum, so bring it back. We're not going to give you any money for it. We're actually going to charge you for a second prescription that's much more appropriate for your condition, right? So, we need unique and different strategies. I have put on the overhead, do Bugs Need Drugs is an excellent program. RX Files, excellent, but they're education programs. They're not resourced to provide the, for example, audit and feedback to physicians in the community that they need. We could change that. We could certainly resource them to do other jobs, or maybe that's somebody else's job. But we know from much literature that education alone is not sufficient to drive the practice change that we need. It's also been mentioned that we don't really have access to really clear guidelines that apply to all prescribers. I don't think that it's very useful for pharmacists to have a different set of guidelines than the dentists, than the nurse practitioners, than the physicians. So we've talked a lot nationally about a need for coordinating these efforts. We also need a guideline in this country for when not to prescribe. I think that's really important support for individuals. We need to make it very easy for clinicians to do the right thing. And I could talk another 15 minutes on what some of those strategies might be, but I'm actually getting a warning sign about my time already, so I will move on. I realize that one of the main reasons for organizing this symposium is to talk about what a provincial approach might look like and what we need to think about as far as a provincial approach. I'm unfortunately not able to be here tomorrow, but I'll just mention a few things that come to mind for me. I think moving to a single health authority, that should be authority, I shouldn't have used region. I think it brings a lot of opportunity, but I think we need to be very, very thoughtful about this. Though another thing that I've learned in my own practice, and I think Justin and Shaqil are going to talk about their ICU practice, is that building a trusting relationship is critical for practice change. That one-on-one that you have with individual clinicians, that relationship is really very key. It's very key in academic detailing. That's been shown and established, and Lauren is going to talk about that particular aspect. But I don't think stewardship from afar by some provincial organization is going to serve us well. So, and I think we need to think about that when we think about a provincial approach. I also know there's some great work happening in the province, and I would hate to lose sight of that work or lose track of that work in an attempt to bring everybody into a provincial approach. Sometimes what you see in that sort of activity is coming to the lowest common denominator, and I would hate that to be something that happens here. I also believe that we need to invest in local support. I know people who have been denied money to go to a stewardship symposium or do an online course on stewardship, and I fear that that's an error. I think we need to build local expertise and training, and people have to be able to go off on-site visits and see how others are working and doing. One super key thing that's been mentioned before is leadership. So who's in charge of all of this? And I hope that that forms a huge basis for the discussion tomorrow. But who do I talk to about a plan that I want to have? Who's in charge? Who's going to make the decision about who gets resources and how they're going to be spent? And then obviously communication around all that is very, very essential. Turf wars should not be tolerated. That's not really acceptable moving forward in my view. We need to build on our strengths and share best practices. A very small example is, of coordination is this week, Antimicrobial Awareness Week. I would love to see next year or a day very soon that we would have a provincial strategy for this campaign. All of us did our own little thing. The students, pharmacy students on campus, did a great job last week because they're off this week. They invited their medicine colleagues and they had a bunch of activities and they taught appropriate antibiotic use to their fellow students on campus. And I know other groups did things, but we didn't coordinate those activities. Think what we could have achieved if we'd all worked together with respect to Antimicrobial Awareness Week. So I'm going to end here because I'm getting signals that I've gone over time. But lack of accountability is, I think, one of our big issues and challenges. It relates back to leadership. We need to set goals, we need to set timelines, and we need to measure and report and be accountable. We're not very accountable in our healthcare system. The last bullet point from here, sorry, oops. The last bullet point actually comes from that Communicable and Infectious Disease Steering Committee Task Group on Antimicrobial Use Stewardship. Now that's a mouthful. That their final report to the Public Health Network Council. So those are the things that they suggest are a requirement. So I will just finish by saying, ultimately we're accountable to our patients. You heard Heather earlier. It should be patients that are front and center for us and also the citizens of this province. And I would just urge us to get organized and move forward, even in very small steps. I think this symposium is a wonderful step in that direction. And I'm very grateful to be invited today. Thank you very much.
Thank you very much, Yvonne. Now I am delighted to invite our colleagues from Nova Scotia to come and join us. And they also have provided there's a paper copy of their presentation in your folder. Andrea Kent is the Antimicrobial Stewardship Clinical Coordinator with the Nova Scotia Health Authority and a pharmacist. And Dr. Paul Bonnar is with the Infectious Diseases Department of Medicine at Dalhousie and the Medical Director of the Nova Scotia Health Authority Antimicrobial Stewardship Program. So let's hear Paul and Andrea.
Thanks very much for inviting us here. We have no disclosures. Nobody wants to pay us any money. We'd like to give a brief overview of Nova Scotia itself and our new NSHA, provide a structure of what our AMS program looks like and what we have been doing for the past 7 months, share a few of our successes, also share some challenges and lessons learned, and where we're going from here. So that's what we hope to accomplish in the next 40 minutes or so. So this is Nova Scotia. We have a population just under 1 million, of which half of that patient or population lives in the Halifax area. So about over 400,000 people live in the city of Halifax. After Halifax, our largest area is Sydney, Cape Breton, and it's about 30,000. Outside of that, towns and villages that have populations of 12,000 or less. We are an area of about 55,000 square kilometers, about 1/10 the size of Saskatchewan. So when I get into issues of talking about geography, you have it 10 times what we have. We have 43 hospitals. One of those is a tertiary care facility. We also have a pediatric facility that not only looks after Halifax, but looks after all the Maritimes, so New Brunswick and PEI as well. And those are both located in Halifax. We have 9 regional hospitals and 1 large mental health facility and a forensic unit. The remaining 30 hospitals are sort of a combination of small acute care facilities and long-term care facilities. I went backwards. There we go. Oh, just wanted to bring some pictures of our beautiful province. So in April of 2015, we became Nova Scotia Health Authority. Prior to that, we were 10 health districts in a small province. That was a lot of... So In April, about 2 years ago, we combined into one NSHA, Nova Scotia Health Authority, plus the IWK. The IWK didn't come in line with us because it was felt that pediatric had some specialties that might get lost in the larger area. As well, they weren't just a provincial, they were a maritime thing, so they are their own separate entity. NSHA is a matrix system in their how we're put together, which can be a bit complex, but essentially we're trying to do things standardly across the whole province. But there was concerns with half the population being in Halifax, and Halifax being so concentrated that they would sort of take over everything. So in order to try and help that a bit, we created a 4 management zone breakdown. So this is what it looks like. The purple area is the central zone, which contains Halifax and half of our patient population. The brown area is the eastern zone, the green area is the northern zone, and the yellow area is our western zone. The AMS program came into place officially in February of this year, but we didn't have all the players in place. Like Paul didn't officially start till July, although he was doing lots of work before he officially came on board. We have Paul and I as the co-leads, and we're both 0.5 positions in those roles. We have a 0.5 microbiologist who's also in a provincial role. I'm sorry, I keep ignoring this end of I'll try and look down here more. And then we have 4 pharmacists each in each of the zones, or 1 pharmacist in each of the 4 zones. 2 of them in the one in central zone and the one in eastern zone are full-time. And then the other 2 are just 0.5. And then we have 0.5 admin assist to help us out. I'm going to pass it over to Paul.
So, as mentioned before, committees isn't stewardship, and that took a lot of time to get across to our leadership, and eventually we got there. Although not the most exciting slide in the world, it was particularly important for us to have things separate. So let's go and grab your laser pointer. So there's kind of 2 streams. So this is our main stewardship steering committee, mainly the clinical team and a few other stakeholders, and right here. And then so underneath that, we have each of the zonal subcommittees. So these are working groups within each zone. Because as this was being developed and as was just mentioned, we wanted to keep, folks that are doing great work, keep them engaged, obviously. So, keeping them involved in zonal subcommittees and keeping that work going and keeping all that local resources intact. And then we report up right to VP fairly tightly, and we meet with them at least once a month now, VP Quality as well as VP Medicine, which has actually worked out quite well. So having that streamlined reporting has been nice as challenges have arose, and particularly getting ready for accreditation. The big sticking point was the green boxes, and that was traditionally in Nova Scotia, all the PPO work, all the formulary work, a lot of that was done by the ID pharmacist. And, I was very concerned, and we were all very concerned, that stewardship, our, limited resources we'd have would just go into developing PPOs and formulary. So that was a kind of a big discussion point, and we have kept things separate. Obviously, we're represented on the subcommittees that deal with PPOs and formulary, but that's not all we do, obviously, and that took a while to convey to folks. Again, it was very important to us early on, given the time crunch of accreditation coming, to get a good strat plan in place and having that visible and available for everyone across Nova Scotia, and setting out clear vision statements and clear tenets that talk a lot what was just mentioned in the previous presentation, again, about really promoting those regional strengths and, the thought that everything is local and really building on that. And then, working in a collaborative manner. So showing how we can help folks in Sydney, Cape Breton that may not have as much resources. How can we in Halifax help and things like that. Obviously, we want evidence-based recommendations. And then very important to us was that open, transparent program. So, having a website that's easily accessible, well, relatively easily accessible, but an internet, not intranet, and building on our small successes going forward. So, trying to keep our scope as narrow as possible and then building on that going forward was very important to us.
So what have we accomplished? One of the first things we needed to do was to create a way to share documents and communicate where we were spread out across the province, our program team. So at NSHA, they had access to the SharePoint, and we had a SharePoint site set up. On that, we house our policies and documents that we're working on that can be read and changed and all done by all members of the team have access to this, and it gets rid of those email strings of things going back and forth and everybody making changes and nobody knowing which is the most recent copy that you've been working on. We also house presentations on here that have been done so people can share the slides and work and makes less work for each of you when you're trying to do those types of things. The next thing we did, once, as Paul already mentioned, was we created an NSHA Antimicrobial Stewardship website. For us, it was important that it was accessible outside of our hospital system. It couldn't be part of the intranet system. We wanted a physician in their office to be able to see the documents. We wanted the public to even have access, and at some point in time, even though we don't have a lot of public information on there now, there is that potential to do that. So our website right now holds our antibiograms for the whole province, recorded education sessions that we've done, our antimicrobial handbook, contact information, our strategic plan, and our quarterly reports.
Yeah, so again, having that strat plan early on was quite beneficial, I think, for us, and to get, it gets signed by the ID division, by the VPs that we report to, so that we had good buy-in and then could use that going forward. So that was quite helpful to get going with accreditation prep and getting going with our program. And then our quarterly report. So, having that available and disseminated across the province, and then we developed kind of a one-pager for it that could easily be disseminated. Again, both in prep for accreditation, but just to get folks aware of our program, it worked quite well.
No. Yeah, there we go.
Is this you?
Oh, yes. So education was a big focus when we first got started, especially since four of our pharmacists, 3 of them didn't work in infectious disease prior to getting hired into this role. They had come from various backgrounds clinically. We had, as in the bios mentioned, that Paul has done his fellowship with Antimicrobial Stewardship at University Health Network. We used that connection to get me up there for a couple of weeks, met with all of the team members and took as much advantage of that time to get and gather information to bring back to our province. We enrolled our AMS pharmacists in online programs such as Stanford's and one out of FutureWorks out of Dundee, Scotland. And we used some of the resources that University Health Network had given us, as well as our local ID physicians and microbiologists, to hold an education day with our team. And in doing that, we did some role playing, and we had specific cases, and the idea behind it was to start to develop them and to give them the confidence in leading audit and feedback rounds. And we've tried to instill in the pharmacist to think beyond their typical role as a pharmacist and to think more towards being antimicrobial stewards. And Paul and the physician group have been very supportive in allowing the pharmacist to work to that role, and that has been very, very good. I list here we've really tried to target as many groups as possible and taking advantage of any opportunity to get our message out there. And initially it's just really been, hey, we're here and this is what we're about. So that, you know, when that question comes around, because we just had the accreditors in October, that was my fear, that they'd ask that one person that didn't know we existed yet. So that was our main goal. We use technology to reach a larger amount of people and have recorded a lot of our sessions and post them on our website so they can be viewed by people afterwards. So this one isn't in your packet because I don't have permission to be publishing it, but I can speak about it. This was a point prevalence study that was done on antimicrobial use in Nova Scotia hospitals by Emily Black and colleagues. And it was done in about 2015, which was before we came into play. But the information on it was coming out right around the time that we were starting to pull together as a program. And the data was very helpful to us to give us our directions and initial steps and strategies. And so as you guys go forward and look at doing things provincially, it may serve you well as a good starting point because we certainly have found it useful. A couple of the key points that came out of it was that the overall prevalence of antimicrobial use was 30% in our hospitals. The highest being in ICUs at 47% and surgical units at 43%. And about over 60% of our antimicrobials were IV.
Yeah, so the timing did work out quite well and let us really, gave us some impetus when we were engaging stakeholders on our early initiatives on what we want to do. So it was quite helpful. And so our main intervention to begin with was prospective audit and feedback. In Central Zone, so Halifax, there had really been no formal audit and feedback really at all. So that was a brand new startup. And as I'm sure most of you are aware, getting early buy-in from stakeholders was key. Presenting some of that data to them as well as what are other folks doing across the country allowed us to get in there with ICU, and they've been very receptive. So the way this looks on a day-to-day is, well, we meet twice a week with each of the ICUs in Central Zone, daily in Cape Breton and Sydney, the Eastern Zone. And a lot of it is audit and feedback, obviously, but very much academic detailing. So, it takes about 15 to 20 minutes. We're fairly quick, but really try and, do teaching as much as we can, making sure we teach at least one thing each day to kind of prove our worth and make it valuable for them. And that's with the whole ICU team. So staff come quite often as well as the rest of the team. So, residents and clerks and whatnot, as well as usually a nursing rep is there too. So that's gone quite well. Obviously, that's only been up and running in Central Zone for about 3 to 4 months. So our data, our antimicrobial use data is coming for that. The way this has worked outside of Central Zone has varied. So it's very much a targeted approach in Northern Zone. And again, that was mainly based on what they were doing already, where they were targeting ciprofloxacin, piperacillin tazobactam, the carbapenems. So we just basically continued that with dedicated pharmacy time, and I check in with them once a week. And then in Western Zone, the focus has been much on UTIs or asymptomatic bacteriuria, which they kind of identified as a problem there on their own. It's a problem everywhere, of course, but they're very keen on carrying that forward. So that's where we kind of jumped in, and our pharmacist there has done very good work on asymptomatic bacteriuria through audit and feedback, which hasn't worked everywhere where it's done for asymptomatic bacteria, but he's done quite well. So all this was, around using the local resources, what was done already to some degree, and then beefing that up with support both from myself, Andrea, and then the other leadership of the program. And, I think we do have a bit of a unique experience, or certainly talked a little bit about earlier this morning, where, we have, using communications, checking in once a week, mainly building up that pharmacy strength, resources, and then with support from myself and the other physicians. So that's been our core. Besides that, we've done a few things, well, mainly one thing across the province. So policy-based that could be implemented across the province because, with over 40 hospitals, you can't obviously do everything everywhere. So getting something in place, at least in the tiny hospitals in North Sydney, you could have something there, at least some stewardship intervention. And a lot of that was the IV to PO conversion policy. So as you're all aware, having automatic or things that clinical pharmacists could automatically change with some criteria to do so. So a lot of communication was around that and developing that policy. And I mean, things were being done to varying degrees across the province. It's just kind of merging that into one policy and disseminating it out to end users. Our beta-lactam allergy project is very much in its infancy as well. A lot of this is based on the good work being done in New Brunswick. If you haven't come across it, if you Google for New Brunswick stewardship, they have a great handbook which has all the cross reactions for the RSI chains. And they've been very successful with pre-op prophylaxis, focusing on cefazolin allergy being distinct from beta-lactam or penicillin allergy. And they've had very good buy-in from anesthesia and surgery, so much to the fact that we had surgeons and anesthesia come to us saying, why don't we do that here in Nova Scotia? So we've been developing that project plan and our materials around that and moving that forward. So we have an algorithm in place and very much focusing on cefazolin being a distinct antibiotic compared to other beta-lactams. Formulary review, Andrea's been doing most of this work, but with all these different health authorities that have merged, there's all the different formularies. And it was amazing how different things can be within our small province. So amalgamating all that into a reasonable formulary, and by going through that, taking the time and the opportunity to clean that up a bit, and what, or if any, restrictions are we going to have in place? How does that look? What's ID's role? Because there's not much, well, there's one ID physician outside of Halifax for the whole province, so it's very much centralized. So how are we going to deal with restrictions in Cape Breton, Sydney, which is 4 hours away from Halifax? So those things we're still working through. Microbiology. So we're pretty lucky, I think, to have dedicated microbiology funding, 0.5. The physician filling that role is dual trained, so it works out great. And I'm not sure how it works in Saskatchewan, but our labs are very much just in the hospitals, and mainly in the Halifax is the main reference lab, so that's where the MALDI-TOF is. There's no MALDI-TOFs outside of Halifax. It's all more traditional testing. So we get a lot of samples sent into us in Halifax. But also there's huge amounts of variation on how things are being reported, let alone which antibiotics are being reported, but how do vancomycin reports go out, right? So, what are the appropriate targets for trough levels? It's all over the place. So that's still something, obviously, we're working through. But having that dedicated microbiology resource, because that, as you know, huge amounts of work, having them dedicated to that, I think will be very valuable. And I'll talk about the urine as future projects coming up. Is this me? Yep. Yeah, I guess. So metrics, lots of talk about metrics. This will come up in our challenges as well, but we have different systems, of course, inside Central Zone, Halifax, and outside of Central. And when we started, there was really not much antibiotic use data being collected or reported. So, lots of work to be done, still working on it. In Central Zone, we do have DDDs available. That's dispensary data and quite valid. What we did have available to us early on, and like way back in April or so, was purchasing data. And as you're all aware, purchasing data has lots of flaws to it. Obviously, it's at an institutional level at best, and some hospitals buy for the outpatient antibiotic IV use and some don't. So it gets very murky. But at least it was a starting point for us. It was relatively easy to summarize and report, and it was something to have in our back pocket. And, I'll just bring it up. This is for Piptazo across the different hospitals. So we had the DDDs available, standardized by patient days as well as cost by patient days. And usually what we can do is show, at least across the province, there's a huge amount of variability. And variability is always good to show, because clearly some things are going on here, some things aren't going on there. And you know, it's a starting point to look into more granular data. So I only showed Pip-Tazo here across the different institutions, but for example, things like carbapenem usage and vancomycin usage were higher in places by patient days outside of Central Zone or Halifax. So it did, you know, bring up some important trends that have allowed us to look at a little more granular level. Just a small report here. This is from Steve Smith, our Western Zone pharmacist, who has been focusing on the asymptomatic bacteriuria I was talking about before. And he has established he's been there for a while anyway, so he already had good connections built up. And that has allowed him to really engage clinicians when he's looking at urine culture results. So he gets urine culture results every day and kind of goes through them, and will contact the physician and say, look, patient has no symptoms, do we really need this antibiotic? And this is just a very preliminary data during August, I believe. And basically 7 out of 7 times he recommended that they did stop the antibiotic. So he does have good buy-in, and just example of building on that local resource that was already there.
So we had accreditation coming up in October, and the IV to PO step-down conversion policy went live the end of July. So in a very short time frame, we tried to sort of get some data that we would have something to present to the accreditors. I normally wouldn't go 6 weeks into a new policy looking for data, but we did anyways. So this is what we came up with. The NSHA 2015 data, that is from the point prevalence study. And in the original slide, I said it was over 60%. But we felt that the policy itself lent itself well to medical patients more so than ICU or surgical patients. And we didn't have the resources to do a full audit of all patient units like the original study was done. So we just focused on medical patients, and so I was able to contact Emily, and she was able to tease out her medical patient data for us. So that 50% is how many was the percentage of medical patients that were on IV compared to PO. So we did have a slight decrease, which was positive. Eastern Zone tended to be the one that was the outlier, and it was one particular hospital in Antigonish that had 85% of their antimicrobials as IV, and they really skewed the data. So if I took that out, we actually were down closer to 40%. So we did make some improvements in that short period of time, and we now know that that hospital is a target for us to go talk and see what we can do about their IV use. So we'd like to take a few minutes and share some successes that we've had. One success is our physician pharmacist co-lead model. And the model to have a physician and pharmacist in leadership roles of the program is recommended by the IDSA Antimicrobial Stewardship Guidelines. Having a physician with an ID background is also recommended, and we not only have that, but we also have someone with their specialized training in antimicrobial stewardship. So I think that has been a good win. And then we were up and running in a short period of time. We had exactly 7 months from the time that we came into being till our accreditation date. So to get everything up and running in that time period worked well. We did have our accreditation just a few weeks ago, and initial reports were well received, and both the leadership of NSHA and the accreditation surveyors highlighted the antimicrobial stewardship program as things that NSHA were doing well. We built on what was already existing. We did some gap analysis before we started, and we looked at what was happening, and we tried to go and support. So part of that was to do a little bit of a road show, and I went around and met with at least the regional sites and mostly the pharmacy teams, but did try to connect with physicians and IPAC personnel and people who were involved in antimicrobial stewardship to let them know that we were here to support them, that we weren't coming in to change what was already existing and having something completely different, but that we were going to be a support and a source to help them build on what they're already doing and then hopefully move from there.
And yeah, again, just finding those champions and those, besides, you know, pharmacy engagement, the physician engagement, a lot of that was already in place, just making sure to keep those connections intact, that we weren't coming in, you know, changing everything. We have to do it this way, and there's only one way to do things. Education sessions, so a lot of our time has been doing education. We all know education only works so much, but we've done a lot of it around, you know, making those connections, reaching out to folks. We've done, you know, nursing, medicine grand rounds, nursing a couple of times, pharmacy talks. And what we're trying to do, Antibiotic Awareness Week this week back home, is a lot of patient engagement this week. So that's something we've definitely lacked, but trying to build on going forward. I talked about audit and feedback. We're very much in a hub and spoke type model, so we have the hubs in each of the zones, working on building up those pharmacists' expertise in stewardship, and then working out to the small spoke sites within each zone. So obviously that's kind of a long-term project. And then just building those alliances and collaborations, both with Saskatchewan, and look forward to our future collaborations, given our, you know, similar population to some degree, but also with New Brunswick, PEI, and Newfoundland, and having some early meetings as Atlantic Province group has been very good. And the IWK, so Andrea talked about the IWK being a separate health authority. They also have their own stewardship program run by mainly Kathy Slater, who is fantastic, and they have a great program. Their reach obviously is limited to just IWK, but they have expanded. They've used the Spectrum app, so they're on that, and they've reached out to across the province, mainly, you know, in pediatric wards outside of Central Zone. I think you're up.
So this is the Leaning Rock in Digby, and when we got to the idea about challenges, I thought this was a good model, because even what appears to be impossible can be achievable. So, financial, first off. I'm going to talk a little bit about pharmacist end, and Paul will address the physician side. There was no new money, I'll have you know that. Even before I got this role, I was manager of one of the pharmacies in the Northern Zone, and we were sitting down with our new senior director of pharmacy, and she was talking about the Antimicrobial Stewardship program, and she tasked all of us as managers to get together as a group in our zone and figure out how we're going to cobble the money together to create these positions. So it looks different, and how it happened was different in every area. So in Northern Zone, we took, you know, 0.1 from one hospital, 0.1 from another, and I gave up 0.3 but said it had to be at my site, and that's how we created a Northern Zone position. Down in Central, they had a vacancy in med safety, so they moved that position over. In Western Zone, they couldn't come up with any cobbled money. All their positions were filled. They had no leaves of absence to work with. So they, oh dear. So they moved to whatever hospital had the successful candidate. They would just figure out how to. And our initial take-up of a pharmacist wanting to do it was really low, because they thought that they were going to get stuck with having to do this off the side of their desk. And so it took a lot of work and going down and talking with them, and agreement from management that, you know, we will set this aside. It's not something you're going to do off the side of your desk. You do get the dedicated time. So we've been have done that.
Yeah, so on the physician front, we got 1.0 FTE for a physician, so I'm filling 0.5 of that, and I do 0.5 clinical, and then the other 0.5 went to the micro aspect of things. So that was new funding we were able to leverage, mainly from the pressure of accreditation coming and ID not being willing to give up our 3 clinical ID time to stewardship. So, digging in and using Accreditation Canada, that was quite helpful to get at least that resource. And then we did get some administration funding as well.
Trying to get resources for zone physicians, but
Yeah, getting funding for each of the zonal physicians has been very difficult, but still working on that.
So we mentioned a little bit about the technology issue and the two computer systems. So Central has BDM and the rest of the province has Meditech. So that's one issue. Nothing talks. Half the province has Omnicell, half the province has Pyxis. So again, nothing talks. And then we were struggling to get our DDD reports out of Meditech, which is why we had to go to, and one of the issues, and this may be, I don't know if it's learning for anybody else, but it was learning for us, is how the SIVA, the Central IV Admixture programs, get entered into the system became a problem. So what we've had to do is change how we enter it so that we can get the data that we need. And now we're going to be a little proactive and going forward. So in the sites where we've gathered that data and we figured out how to make that work, we're now going to standardize that process of entering it across the province. So once we start to gather data in other places, that will come into play. Geography was another issue, and like I said, you guys are going to have 10 times the problem we had. With everything being centralized and very central focused. I think the ways that we have overcome that has been using technology, having our program staff in each zone, using what works for those areas and giving some autonomy to the zones and how they will make things work. As well, some interventions can be broadly spread again and not dependent on ID services and having clinical pharmacists in all the areas to make this truly a provincial program. And I think also it has been helpful to have the code leads from two different backgrounds. And what I mean by that is Paul has been very centrally focused in where he has done his work. And my entire career has been in rural hospital. So we bring a different lens to that. Communication. That was a whole other issue. When we had our rollout of our IV to PO, we thought we were working with communications with NSHA, and it was a disaster. We found out a week after it went live that the communication didn't go out, and apparently there's a policy on how to communicate policies that the communications office wasn't aware of. So we've been working with them, and I think we've got it worked out, and they are now running our antibiotic awareness week while we're here, so hopefully that's all better. Yeah.
Yes, I think pretty much done up on time, and we can chat more later, but obviously talked about expanding our audit and feedback, using, the experience nurses have and all the great work nursing does already, expanding on their role and applying that to stewardship is definitely underutilized for us. And working with research, Emily Black, who did that point prevalence, is continuing to work on stewardship research, and obviously patient engagement, and then expanding on microbiology tools as well, particularly around physicians calling to get the urine culture result for inpatients. So similar to what Mount Sinai does already, not just processing all the urine cultures, but requiring the physician to call when they actually want the result as opposed to just treating asymptomatic bacteriuria. So lots on the go, and I'm sure we'll talk a little bit more about in a few minutes, but thanks again for inviting us, and I'm sure we'll learn just as much from you guys, so thanks again.
So Andrea and Paul are going to be here for the interview panel, which is in an hour, so I think that's, is that all right? Or did anyone have a pressing question that they need to ask right now? Well, that's very nice to hear from people who have walked the path that we want to walk, and also kind of weirdly reassuring that they too have those cases where you either laugh or you cry. So for the next part of our agenda, we've got a few things going on. We've got a spotlight from Saskatchewan that has 5 presentations, but they'll be split into 2 15-minute presentations and then a half an hour break and then 3 15-minute presentations. So what I'd like to do is call up our before the break presenters. So Shaqil, Justin, and James, could you join me on the stage? So Dr. Shaqil Peermohamed is the physician lead for the Saskatoon Health Region Antimicrobial Stewardship Program, and Justin Kosar is the pharmacist lead, and they're going to talk about what they're doing at Royal University Hospital. And then Dr. James Irvine is going to talk to us about the Northern Antibiotic Resistant Partnership. And in your folder, there's a flyer about NARP and also a position statement as well as James's presentation. So, Shaqil?
Good afternoon. Thanks so much for having us. So Justin and I are really excited to share some of the progress and some of the preliminary results of some of the work we've been doing in our intensive care unit. So the objective for our presentation is to share preliminary findings from an ongoing study related to implementing handshake stewardship in an intensive care unit in Royal University Hospital in Saskatoon. Neither of us have any disclosures. I feel like this is the obligatory slide to start off with when we're talking about antimicrobial stewardship, but it does set the ground that when we look at antimicrobial usage in hospitals, up to 50% of usage has been found to be inappropriate, whether that's providing durations of therapy that are longer than necessary, treating non-infectious or non-bacterial syndromes, or treating pathogens or isolates that are colonizers and contaminants and not actually representative of true infection. There was some work that was recently published and presented at ID Week in San Diego this year, which also showed similar findings in critical care units, where up to 30% of prescriptions provided in ICUs were found to be inappropriate. And like I mentioned before, such inappropriate prescribing was due to treatment of colonization or contamination, non-infectious or viral syndromes, and prescribing treatment that was too long or too broad. I think it's important to remind ourselves that consequences of inappropriate antimicrobial prescribing practices do include increasing antimicrobial resistance, costs, and adverse patient-related outcomes, including increasing length of ICU stay, C. difficile infection, and mortality. Antimicrobial stewardship is a core quality improvement initiative and now a recognized required organizational practice in Canadian acute care hospitals. We felt that implementation of antimicrobial stewardship in ICU settings was particularly important given larger volumes of antimicrobial use and higher proportion of broad-spectrum antimicrobials. The ICU also represents a very unique, high-stakes environment due to the acuity of patient illness that can be associated with prescriber reluctance to de-escalate therapy or discontinue antimicrobials. For those reasons, we knew that when we were going to intervene in the ICU, we needed to have a collaborative approach. So we needed a strategy that was tailored to the critical nature of patients admitted to an ICU and also fostering a collaborative culture of judicious antimicrobial prescribing. So in terms of some background on this concept of handshake stewardship, this was expanding upon a concept of prospective audit and feedback, and there's some literature related to pediatric antimicrobial stewardship in some facilities using this particular strategy that emphasizes particular values: verbal, face-to-face discussions, shared decision-making with a conveyance of trust and collaboration, and bidirectional exchange of information and education. So our hypothesis was by employing a handshake stewardship model with prospective audit and feedback in an intensive care unit, we could optimize antimicrobial usage as part of our novel program in Saskatoon. So Justin's going to tell you a little bit about our study.
So what did we do? Well, as Shaqil alluded to, it's kind of one of those things where the ideal environment is one where it's a collaborative environment, because the biggest problem for stewardship, or the biggest concern, is that fine line where you can do a lot of good, but you can really tick people off very quickly. And kind of riding that line, it becomes very difficult. So it was a quasi-experimental study design that was approved by the Research Ethics Board at the University of Saskatchewan. It's also got some accessory funding and support through Health Quality Council in Saskatchewan. And we were actually very lucky to have Heather Thiessen, our patient advisor this morning, as our patient family advisor on our research group. So nice to keep our eye on the prize and as to why we're actually doing this. So it was carried out in 2 sites, essentially Royal University Hospital, our site that we work at, with a comparative group of St. Paul's Hospital. This is basically a visual diagram of what we're doing. So the study was approved and started in November 2016 with anticipated completion coming up at the end of this month, with our intervention obviously happening last year, November, and comparing that to St. Paul's Hospital, which has had no active intervention. The methodology is essentially focused on 3 main things: process measures, balance measures, and then obviously outcomes. The process measures generally center around number of, and type of ASP recommendations and their obvious rate of acceptance that happens within 24 hours. We use 24 hours because that's generally, from a design perspective, what we do is typically 3 times a week, Monday, Wednesday, Friday, we'll round at RUH. It's an up to 18 bed, although it's more usually a 15 bed ICU care unit. And we spend scheduled rounds at 1 o'clock on Monday, Wednesday, Fridays with the ICU group, including the physicians and residents. And we go around the circle, going through everybody who's on active antibiotic therapy. The rounds themselves take about maximum 20 minutes. It's an average of about 16 and a half minutes to round through. With that, though, there's about 45 minutes of pre-work where Dr. Peermohamed and myself will go through relevant culture results, imaging studies, any other background laboratory work or past medical history that deemed to be relevant to assess our recommendations going forward. So we did the process measure around obviously our recommendations and their acceptance. We also wanted to see how we were doing in terms of physician buy-in, and this came into a physician survey in May 2017 about their attitudes and perceptions, i.e. did they like us being there or did they not like us being there? And it was very interesting to see kind of what ended up happening as a result of us measuring this further down the line. Our balance measures are the classics: rates of Clostridium difficile infection, readmission to ICU, and mortality. Now, I'm not sure if we're necessarily powered, but I think the important thing is realizing that it will go to supplement other data where, despite stewardship measurements and narrowing of therapy, you're not necessarily infecting mortality and perhaps helping it. Lastly, of course, outcome measures were overall antimicrobial usage. Our ability right now to measure is pretty much limited through centricity to DDDs, so defined daily doses. We don't have the ability to do days of therapy as of yet. Obviously, IT, nobody in this room needs to be retold that IT is always fun to deal with. And then obviously we're looking at broad spectrum versus narrow spectrum antibiotic usage. So how did we define that actually? Well, this was an adapted breakdown of antibiotic by classification. And you'll notice that class 1, 2, 3 are traditionally associated, at least according to this classification scheme, as narrow spectrum. Some might argue that ceftriaxone is fundamentally wide, but then again, when you're reflecting upon the patient population in ICU, so there are arguably are many times when you're downgrading from, say, a piperacillin and tazobactam in class 5 down to a class 3, and therefore it's associated with a more narrowing of therapy. So result-wise, a couple of things to note. The most important thing is what happened with regards to our recommendations. And this, interestingly enough, echoes that first slide that we saw at the beginning of our presentation, where the majority of our recommendations are centered around discontinuation therapy, once again highlighting the need for therapy or lack thereof, de-escalation of therapy, and then obviously duration optimization. A few other things to note, though, is that stewardship often gets confused with de-escalation, with it being forgotten that we also are around rational and appropriate usage. So I'd like to point out that we have had instances where ID consultation comes into play, and escalation of therapy also becomes some of our recommendations. So we're not necessarily the police all the time, we're just the appropriateness people. Breaking down our recommendations, we have 317 patients assessed. This is 9-month data. We haven't got our 12-month data yet. 319 patients assessed for a total recommendation number of 226, an overall recommendation acceptance rate of just north of 90%. and equally distributed across all categories. Getting back to that survey, turns out that they don't mind us there at all. 93% actually prefer the format of verbal face-to-face modeling for ASP rounds. 86% believe that they do not impede upon their autonomy for prescribing or agent selection, and 86% agree that ASP rounds overall improve quality of patient care. Using more, and this is also kind of what's the impact in terms of their daily practice. Almost everyone has decided that as a result of our rounds, they're starting to use more targeted therapy in their empiric dose selection, and obviously moving towards a shorter duration of therapy overall. This one's very interesting as well, and once again reiterates why patients, or rather prescribers, prefer the format that we're employing. They have said that they appreciate the formal face-to-face verbal interaction, and obviously do not like the idea of written suggestions without verbal communication happening as part of the interaction. So the, I'm not saying we're the most attractive people, but they don't mind seeing us, so that's nice to know.
So in terms of some of our other results, this is a control run chart which shows the monthly usage of broad spectrum antimicrobial use in our ICU when we started the study in November 2015, and in November 2016, where you see the arrow, that's when we started our intervention with these rounds in the ICU, and you can see a decrease and a shift in terms of the monthly usage of broad spectrum antimicrobials. So then here again, you can see, consecutive points in terms of using quality improvement methodology, where we can see a significant shift in the usage of broad spectrum antibiotics. To put that in another way, the red lines here and the red dots represent broad spectrum antimicrobials and average usage before and after our intervention in Royal University Hospital ICU. And the blue dots and blue lines represent narrow spectrum antimicrobial usage. So while overall antimicrobial usage did not change in the intensive care unit, we saw more than 20% reduction in broad spectrum antimicrobial usage and an increase in narrow spectrum antimicrobial usage by about 29%. And I think these numbers reflect the types of suggestions that we're making to the intensive care unit team and their buy-in as well. This is another way of looking at the data in terms of the proportional usage of broad and narrow spectrum antimicrobial usage, and just visually I think you can appreciate a shift after our intervention where we can see more narrow spectrum usage proportionally and less broad spectrum antimicrobial usage proportionally. The thought is that that would ultimately also then translate into more appropriate use of antimicrobial usage, but the limitation certainly with our study is that we aren't directly assessing appropriateness of therapy. So some of our conclusions here: implementation of handshake, stewardship, prospective audit and feedback rounds in the ICU at Royal University resulted in significant increases in usage of narrow spectrum antibiotics and significant decreases in broad spectrum antibiotic usage. Our current model of collaborative antimicrobial stewardship rounds with verbal face-to-face interaction seems to be favored by the majority of intensivists as a patient-centered QI initiative that does not impede upon their autonomy. And certainly ongoing work is needed to ensure sustainability of this initiative and develop stronger metrics to assess the appropriateness of antimicrobial therapy as well. So one day when I opened up a fortune cookie message, I got a very ominous message, so I decided to switch it around and make it a positive one. And I want to just say that the road to success is never a lonely one, and I would just want to use this opportunity to acknowledge all of our parties that are collaborating with us, including the ICU team, both the critical care physicians and pharmacists, as well as the Health Quality Council, and the Clinical Quality Improvement Program with Dr. Sanch and Dr. Shaw, and then also acknowledging Skipper, the Saskatchewan Centre for Patient-Oriented Research, Heather Thiessen, who's our patient representative, Patrina McGrath, the Antimicrobial Utilization Subcommittee, and of course the Saskatoon Health Region Department of Pharmacy. We wouldn't be able to do what we're doing without all of these supports. Thank you.
Okay, thank you very much for the invite to attend today. I'll be giving sort of a discussion of the other aspect of the spectrum of antimicrobial resistance. This is more from a community perspective, and it's somewhat historical as well, because we started this some time ago. So for those of you from outside the province, the area that I'm from is the northern half of the province, very sparsely populated, about 30,000 people, about 87% of Indigenous populations. But we had been experiencing quite an issue as it relates to community-associated MRSA in a number of our communities. So I'll talk a little bit about the community-associated MRSA, the development of a Northern Antimicrobial Resistant Partnership through a CIHR grant, and funding through Public Health Agency of Canada, and then a little bit about some of the initiatives that we had as it relates to that within our community context to illustrate the value of using community data, community perspective, community needs in terms of development of solutions. So we had a very large partnership. The National Laboratory of Microbiology through Mike Mulvey in Winnipeg was the lead investigator, but we had people from the Saskatchewan Disease Control Lab, a number of different health regions, First Nation health authorities, and universities involved with that. This was a scenario that we had, was lab-confirmed community-associated MRSA, and we at first looked at it from the issue of whether this was in clients related to hospital visits or whether it occurred separately without a hospitalization or without any contact with the health system. And historically, they tended to be more community based. You can see in one of the health regions, there's a significant increase, peaking in about 2006. It was predominantly a pediatric infection, though all age groups were affected. The second area that there's this bump in the early 20s, probably those who are parents with young kids. But it was lots of skin and soft tissue infections, lots of abscesses, lots of cellulitis, but a lot of abscess. When we got the funding to get involved with more of a lab surveillance process, we found that the most common serotype was by far serotype 7, which is a community-associated MRSA. And it's different from many other community-associated MRSAs in Canada, which tended to be the 10, and very different than the predominant MRSAs within Saskatchewan, which tended to be more hospital-associated. So this is a sort of a map showing the different types of serotypes of community-associated MRSA, the red being the serotype 10, based in Vancouver, Calgary, Toronto, and then the 7, which was just in a small pocket of Montana, North Dakota, Wisconsin, predominantly pediatrics in Indigenous populations. And that ended up coming within southern Manitoba, into northern Manitoba, and then gradually spread across northern Saskatchewan and into Ontario. That also went up to Arviat because of the transportation links between Winnipeg and Arviat. And from Alberta, we went down east and up to Bishoko, up near Yellowknife, because again, the transportation links. The different distinction there is the CMRSA 7 has some differences in antimicrobial resistant patterns. We know the factors in terms of impacting community-associated risks, and there's often called the 5 Cs, but there's a 6th one, which is antibiotic capsules or the prior antibiotic use. And certainly if you looked at our circumstance within northern Saskatchewan, when you think of housing factors being 10 times greater than that of the provincial average, and that's an average rate across the north. There would have been some communities with significantly greater than that. So you see the challenges of houses perhaps with 10 or 15 different individuals within one bathroom, what sort of impact there would be with sharing of towels, sharing of arrangements, and the challenges that relate to that. So that was important in our approaches and in our messaging. So a lot of our initiative is based on prevention. We were doing surveillance, we were doing chart reviews, we were doing a lot of lab work, but it was really focused on prevention. So I'll talk a little bit about that. One, there's the active surveillance, which looked at a wide variety of infectious syndromes, and we were looking at sensitivity patterns. And the provincial lab developed antibiograms to different regions within the north. So not just northern versus the province, but having within different regions. And about every 3 to 4 months, they'd feed that information back to the local primary care providers, who could then use that information for prescribing within their area. We developed guidelines for the management of community MRSA and skin and soft tissue infections, really enhancing the use of incision and drainage as a management tool, but also the appropriate use of antibiotics when required. We worked with Northern Manitoba, First Nations Inuit Health Branch, and NIFA, Northern Intertribal Health Authority, in the development of guidelines for not just hospital infection control, but nursing station or health center infection control practices as well, and within physician offices. Developed patient handouts so that primary care providers could provide the information to clients about appropriate management. We did education on non-antibiotic use of respiratory infections, and certainly used the Bugs Need Drugs program in terms of education for physicians, but also within our communities. We developed algorithms as it relates to management of skin and soft tissue infections, and that's been replicated and modernized with the RX files produced this spring. As it relates to public education, we looked at a lot of the literature as it relates to the value added of additional hygiene practice and education. And whether it was in developing countries looking at skin infections, diarrhea, or respiratory infections, or in Alaska, where they've done a lot of work on the development or added features of in-house water supplies, there is a significant value added to hygiene education and hygiene education, even with the addition of water to a home. And so we really focused on prevention of MRSA, environmental management, and controlling transmission. Talking a lot about hand hygiene, cough etiquette, sharing of personal items, with all the challenges that there are within crowded homes. Even environmental cleaning. We even had to educate school janitors in terms of the importance of maintaining soap and towels within bathrooms within high schools. They felt they were things that would create mess or block toilets, and so we had to keep that education up with our janitors within the schools. We also did antibiotic use in terms of education for that. So we used different tools. Often written word may not have been as valued, so we did a lot of language. Local radio within one community would have its own few hours of radio messaging that we'd put across. We had Cree, Dene, Michif, and English radio spots, lots of posters and pamphlets. We did train the trainer for schools, for daycares, for Head Start programs, particularly do Bugs Need Drugs using the puppets, and a lot of community presentations. Also, there's a curriculum developed within the needs of the province in the curriculum programs for First Nations as well as school divisions, and created a grade 4 to grade 6 program on germs away. So this is just some of the activities that are going on with Do Bugs Need Drugs within the communities, some of the train the trainers. Worked in the schools, the high schools. We had one facilitator who traveled around the north, but really was limited in terms of access, so we needed to have local champions. Posters were very well received, and they were very much in demand. I think we were added a lot to the 2009 pandemic issue, or H1N1. This is the grade 4 to 6 curriculum that was developed, and there's a video broadcast that could be done as it relates to ongoing education for new teachers that were involved in the North. And there's a flash animated video game that was available for high school students as well. So this is some of the results that had come at that time. The black are those areas in which we had active surveillance, and the white triangles are those that were passively receiving some of the benefits of the mass media, but not as intensively. Since that time, that's continued on since then, 2012. We use community-based surveillance. We tend not to take public health interventions as it relates to every case of MRSA, but we do monitor case counts within communities, and we'll focus prevention efforts within those communities. A colleague from Australia talked about the idea of unfettered use of antimicrobial agents would be in disadvantaged communities is likely to further promote antimicrobial resistance unless we are doing something about social economic conditions in those areas. But there's other things that can be done too in terms of intensive work in terms of immunizations, work on point of care testing so that we can use more and more appropriate use of antibiotics and things like antibiograms. So there's a number of individuals within the community here, or within the audience here, who have been part of that process, and many more that have been involved as well. And certainly the provincial lab, Saskatchewan Provincial Lab, was very, very much involved with that as well. So this is, I don't get it. Not a single person has joined since we've opened, so with staff written across the front. There's a couple of different resources I've put in the pamphlets there. One is more community MRSA as it relates to Indigenous communities within Canada. And then there's another one on the management of community-associated MRSA through the Pediatric Society. So, okay, thank you.
So before we let you leave the stage, does anyone have questions? Bob has a microphone that he can run over to you.
Hi, I guess more of a comment than a question. I was just interested, Dr. Irvine, that you mentioned having to educate the janitorial staff at schools as well. And I think that's something that, working in the hospital system, I feel is also important, that ensuring that the environmental staff there are educated about, especially when they're cleaning a room after a patient who's left, who has had, a resistant bug or something like that. Ensuring that those people are also aware of the importance of their job in helping to maintain the cleanliness of those spaces, so when the next patient comes in, we're avoiding that sort of continuation of passing the bugs along. So I think just a very important piece, letting everyone involved in these situations know what their role is with regards to stewardship.
Okay.
Thanks. I was interested in both talks, but actually my question is about the management of the CA-MRSA infections that you were seeing in the north. I mean, in our north, we had a similar problem where there was a bit of a lag time before local physicians kind of cottoned on, so they weren't swabbing as much, and they were still giving people cephalexin, and then the people were failing. I actually saw one northern physician with a CA-MRSA empyema because he acquired CA-MRSA from his patients before anyone really even knew that it was a problem, because it was a PVL positive strain, very aggressive infection. So do you have antimicrobial utilization data or anything that you can track to see how skin and soft tissue infection management has changed?
No, we don't. We do have, during the time we did a chart review and looked at antimicrobial prescribing, and then we're getting about every 3 to 4 months antimicrobial resistance patterns. I think what we found was that because we have very small population and fairly close-knit arrangements between primary care and public health, there's fairly close working relationships between them. And so I think the idea of once we started to see these spider bite infections it soon got recognized as MRSA being a fairly major issue. And by communicating fairly regularly back to those primary care teams from the northern hub on the prescribing patterns and issues that they were having with incision and drainage in small communities, I think we were able to get a handle on it fairly quickly. I mean, there's still major challenges as it relates to ongoing issues of infection because of the crowding and water systems, but I think because of the nature of the public health primary care network in a small setting, I think it was valuable. And I think that, as someone else has talked about, I think that'd be an important area that we need to be maintaining as we move to One Health Authority, is having those hubs within the hubs being maintained. So.
Hi, I just had a question for Justin and Shaqil about your study comparing the ICUs in RUH and St. Paul's. You didn't mention anything about what you were finding at St. Paul's in the ICU, and I was wondering, because doctors go back and forth, whether they were carrying messages back and forth between the two.
This one's on. So that was, that was intentional. We didn't mention anything about St. Paul's. For a couple reasons. You highlighted the main reason is that of the 22 intensivists that we have working critical care in Saskatoon Health Region, 18 cross cover. So one of the endpoints that we're going to be looking at is what's the degree of educational translation going across the invisible barrier that is the river in Saskatoon. We don't necessarily want to unblind until we're done, which thankfully is this month, so word's out. But yeah, it's going to be, we have been looking at it in the background, we just haven't reported it out. Trailer alert, or spoiler alert, things are different, so.
Any other questions?
Actually, I'll just add one thing. Interestingly enough, though, on the attitudes and perceptions, we did have a high response rate. So we had 16 or 18, 16 respondents of 22, of which all provide double coverage. So despite having that response of it doesn't necessarily impact their ability to prescribe, or they don't feel like it impacts their autonomy, we may or may not see that actual impact in terms of agent selection at the other site.
Thanks. James Irvine, just a question for you. I picked up on your comment that that's somewhat historical, the NARP work. So I'm just wondering, how are the current activities? Is NARP still active? We know funding challenge is always chronic. But.
So the website is still up. It hasn't been updated. The school curriculum across the north has changed provincially, and so that's not run through all grade 4 to grade 6 anymore. The funding has stopped, though we have continued on community by community surveillance, and we do interventions when we start to see a rise in rates within this particular community, and often we're using resources within the community health workers or community health representatives and public health nurses for that, and in some situations teachers within schools, depending on where we're seeing things. So certainly the resources for it are very limited now. We still are acting at times when we need. There's discussion occurring right now provincially as it relates to how do we continue to survey for community-associated MRSA within the province. Right now, or in the past, it's been lab reported to public health, and that's up for review now in terms of what approaches should be made within the province, and should be the north be slightly different because of the prevalence there. So there's not the same access to new resources for other parts of the country that was available in the past, because often we had Alberta, Alaska, Northwest Territories, Nunavut, utilizing some of our information and some of our resources at the same time. But
No other questions? Questions from WebEx world? Nothing from there? Okay, that's great. I think that will conclude our first spotlight on Saskatchewan.
And I'll introduce the break, but thank you very much.
Yep. So as Valerie prepares to instruct us on what a randomized coffee trial is, I'm going to take the opportunity one more time just to remind everybody about the scratch notes. It's so important that we understand your perspective, whether you're going to be present tomorrow or not. This information that you can share with us about how these presentations has triggered something in you, reminded you of a situation. Those are the kind of things, the barriers, obstacles that you face in your work on a day-to-day basis is what we need to know in order to really truly highlight the needs and the gaps for the province. And after the decisions are made is too late, so this is our opportunity now to have that voice and express. So that's my pitch on that. Please take a moment. Valerie, take it away.
Thank you, Bob. Well, because I couldn't help but noticing that we are a fascinating and diverse group of people. And so I wanted to take advantage of that fact to have us, use our break to do a randomized coffee trial. This was an activity that was introduced to me by Helen Bevan, who is a change leader with the NHS in the UK. And first of all, let me assure you that as an introvert, I have a strong aversion to like cringy and awkward social activities, and this will not be like that. It's going to be super fun. But the concept is that you get to spend the break with someone you might not otherwise have met or spent time with, and you can talk about anything you want. So you will notice that inside your blue folder in the left-hand cover, there is a red dot and it has a number. And you and exactly one other person has that same number. And so you are to meet up with your twin and agree if you're going to go to the bathroom, have a snack, whatever, spend the break with them, and then come back at 3 o'clock. So, okay, so if your number is, did everybody find their number? Thank you, Vanna. If your number is in the single digits, so 1 through 9, maybe you could, start by meeting over by this screen. If your number is 10 to 19, then over by the display table, which the display table is fantastic, so please have a look at that as well sometime. If you have a number in the 20s, maybe you could meet in that corner, and in the 30s over there. And if you do not find your twin because that other person had to leave, maybe there's a group that would welcome you, or you can come and see me, and Bob and I will find you a partner. Okay, disperse.